a case of successful management of uterine atony and postpartum hemorrhage with Carboprost. A 28-year-old woman, Gravida 2, Para 1, was admitted to the hospital for induction of labor at 40 weeks of gestation. She was a registered patient and had an uneventful pregnancy course, with no history of any chronic illness or complication. On admission, her clinical findings were as follows: blood pressure, 120 by 80, pulse, 78 per minute, respiratory rate 18 per minute, and temperature normal. On per-abdomen examination, uterus was full-term size, with a singleton fetus present in vertex position. Fetal heart rate was 140 per minute. Her routine investigations, including ECG, were within normal limits. Laboratory test showed a hemoglobin level of 12.2 grams per deciliter. In the hospital, she received 2 doses of dinoprostone vaginal application 12 hours apart for induction. However, seeing that there was only slight change in the cervix, she was then applied dinoprostone gel 2 mg intravaginally. Approximately 5 hours later, she reported having regular contractions. The cervix was about 3 cm dilated, thick, and posterior, with the presenting part being at -2 station, above the ischial spines. Low-dose oxytocin infusion was started. About 6 hours later, she was noted to be in active labor. However, over the subsequent few hours, she became febrile, and developed a temperature of 38.4 degrees Celsius. In addition, there was fetal tachycardia with variable decelerations. Vaginal examination showed no further cervical changes, but molding of the fetal head was present. She subsequently received artificial rupture of membranes, and thick meconium-stained amniotic fluid was observed. Immediately, a decision was taken for conversion to caesarean section due to failure to progress in labor, a non-reassuring fetal heart rate tracing, and possible chorioamnionitis. She was immediately shifted to the adjacent operating room, where baby was delivered through lower segment caesarean section. The baby weighed 4.1 kg at birth, with ABCA scores of 7 at 1 minute and 9 at 5 minutes. During closure of the uterine incision, uterine atony with consequent hemorrhage was noted, but she was hemodynamically stable. Therefore, manual uterine massage was performed and clots from the uterus were removed. In addition, infusion of oxytocin 40 units per liter of normal saline was started. The average overall blood loss was about 800 milliliter. A blood transfusion was considered, but the patient and her relatives denied blood products due to personal and religious reasons. Thereafter, she also received 1 dose of ergometrine 0.25 mg intramuscularly. There was some decrease in bleeding with the intervention, but it was noted that the uterine atony and the consequent hemorrhage still persisted. Hence, she was subsequently administered another potent uterotonic, Carboprost. She received 2 doses of Carboprost 250 micrograms injected into the myometrium, 15 minutes apart, and 1 dose was given intramuscularly. The treatment was found to be successful, and resulted in cessation of the hemorrhage. The subsequent post-operative course was normal, and she was discharged from the hospital after 7 days in a stable hemodynamic state. At follow-up 2 weeks later, she was apparently healthy, except for some fatigue. Her hemoglobin concentration at follow-up was 11 grams per deciliter. This clinical case substantiates the benefit of Carboprost in the management of uterine atony and postpartum hemorrhage. Carboprost is a synthetic analog of prostaglandin F2-alpha used for the treatment of postpartum hemorrhage unresponsive to uterine massage, intravenous oxytocin and intramuscular ergotalkaloids.